Good afternoon, and welcome to this third in this webinar series on healthcare disparities, the effects of race and racism. I'd first like to just give you a few housekeeping details. This program is being recorded, and the link for the video will be available within a few days. The recording will be shared by email and will be posted on our website, and continuing education credits will be available. When today's webinar concludes, participants may click on the evaluation link in the description below this video window to obtain continuing education credits. My guest today is my friend, Dr. Amaka Inyanya from the University of Pennsylvania. Dr. Inyanya graduated from Cornell University and then went to medical school at Meharry Medical College in Nashville. Following her medical school training at Meharry, she came to Boston for residency at Brigham and Women's Hospital. I was the fellowship director for the Joint Nephrology Fellowship Program of Brigham and Women's Hospital and Massachusetts General Hospital during the time that Amaka was a resident. And I was very happy that we were able to recruit her as a nephrology fellow. Upon completion of her fellowship, she joined the faculty at Harvard Medical School and Massachusetts General Hospital, until she was recruited back home to Philadelphia to join the faculty of the University of Pennsylvania, where she is now an assistant professor. And she has a new role, which I will ask Amaka to describe to us. So welcome, Amaka, and tell us about your new role.
Sure. Thank you so much. Well, first of all, I just want to say thank you for the invitation, Kevin. It's such an honor. And you also forgot to mention that we were on service together when I was a resident. So you were, integral to me choosing nephrology. So thank you again. I'm really happy to announce that I was appointed as the inaugural Director of Health Equity, Anti-Racism, and Community Engagement at the University of Pennsylvania. It's the first of its kind. It's in the Renal and Electrolyte and Hypertension Division. And my goal is basically to oversee the division's efforts to dismantle structural racism, to promote health equity, and to actively engage with the community around Philadelphia, as well as the greater Penn community. So I'm really excited about it.
Great, thank you. Well, we're going to come back to that towards the end of our conversation, because I would like to hear more about how you envision using that role to advance the cause of dismantling structural racism and advancing the cause of eliminating some of the healthcare disparities that we so often see, not just in nephrology, but in all of medicine. I forgot to mention also that you're a second generation nephrologist. So nephrology runs in her blood.
It does.
So we're going to be talking today first about estimating equations and the use of race. But since our audience is broad and there are people who may not be familiar with the estimating equations, can you just describe a little bit for us about estimating equations in general and how they are used?
Yeah, so first let's just back it all the way up and just define what glomerular filtration rate is. And so the glomerulus, just to make it as simple as possible, is a collection of capillaries in the renal tubules, and blood flows from the afferent arteriole through the efferent arteriole. And that filtrate, or kind of the waste that comes from your blood, sits in Bowman's capsule. And so glomerular filtration rate, which is GFR, is the total volume of filtrate among all renal corpuscles, or the unit, the Bowman's capsule and the glomerulus, in both kidneys per minute. So it's incredibly complicated to kind of assess how well a kidney is how well your kidneys are working, if you're thinking about how to do that effectively at the bedside. And so equations were developed to help assess a patient's kidney function at the bedside very quickly without having to do urinary clearance measurements, using gold standard filtration markers such as iallethalamate or iXol, and using more endogenous filtration markers such as creatinine and cystatin C. So equations were developed with using creatinine most commonly to help make that assessment.
So I'm going to break it down even further, simpler. So it's a number that we can use to help physicians and patients understand how well the kidneys are filtering, right?
That's right. It's a number. That's right.
It's a number. Yes. And so we use these numbers as kidney doctors. We use these numbers all the time to stage our patients in terms of how well their kidneys are functioning.
That's right. And the way that we normally describe it to our patients, if you're looking at, let's say, a GFR of 60, we usually say, okay, your kidneys are working at 60%. That's the easiest way to translate that to a layperson, a patient, or a caregiver, is that you're using that number to assess exactly how well their kidneys are working and how well they're clearing the toxins from your body.
So way back when I was a fellow, we
Mhm.
weren't using these estimating equations. We were using a more cumbersome method of estimating how well the kidneys were functioning. We asked patients to collect 24-hour urines, and we use a measure of creatinine clearance as a way of assessing kidney function. And as you described, these equations were really a breakthrough in that they allowed us to sort of estimate kidney function without having to go through that cumbersome process of having patients collect 24-hour urines. So from the MDRD study came the first of the estimating equations, and they used race as one of the variables in that equation. So tell us a little bit more about that. How is race used, and how did it come to be that race played a role in how these equations were developed?
So the equations were developed for kind of the epidemiologists and the statisticians in the room as kind of a regression analysis. And so when you're building a model to look at like the fit of a model, how well it could predict kidney function, you typically think of many variables that you can put in your statistical model to get the best fit. So they're basically looking for various factors that could play a role in terms of kidney function. So they considered age, they considered sex, they considered multiple clinical variables like albumin, BUN, things like that, and they also considered race. So when they put all of these variables into their statistical model, a few of them came out as being significant predictors of kidney function if you were estimating the kidney function. So then again, they measured, especially in the MDRD and CKD epi study, they actually measured kidney function directly using gold standard filtration markers. And then they use these regression and these statistical equations to select the variables that would most closely predict kidney function. And so the ones that came out of the MDRD study, there was a 6 variable equation and then there's a 4 variable equation. They both showed that sex, age, and race and creatinine level were highly predictive of kidney function when you put all of them together. And so that's how we got to those 4 variables. And then secondarily, what they found was when they looked at measured kidney function, again, using isothalamate, at any given level of kidney function, Blacks had higher creatinine levels compared to whites. And they found that in both men and women. So they said, that's interesting. We need to have some type of factor that can account for these differences that we're seeing. And that's how race became introduced into these equations.
So there was probably some biologic plausibility to that, to those creatinines having being higher in blacks compared to non-blacks, because there have been some studies that have suggested that blacks tend to have more muscle mass than whites. Is that true?
So that, Kevin, is where the evidence is most poor. The studies that were cited specifically in the MDR study, they cited 3 studies to justify why they thought those differences were there between blacks and whites. And just to kind of back up, they didn't have many black participants in that study. Out of the 1,600 or so participants, 197 were black, so about 12%. And so what they found in the literature were some very small studies between the 1970s and the 1990s that looked at body composition differences. So there was a pediatric study from the 1970s that showed that, for instance, blacks had less body fat than white children. And these, when I say small studies, these are less than 100 participants. The next study from the 1970s showed total body chemical composition differences between Black and white adults, and specifically showed that Blacks compared to whites had elevated or higher total body potassium and calcium. And then the last study showed looked at hospital workers, so 60 or so healthy hospital workers, and found that Blacks compared to whites had higher serum creatine kinase levels. Um, and so that is what they use to kind of describe muscle mass. To this day, we don't have any. First of all, there is no way to determine muscle mass. While someone's living. If you have a cadaver, you can easily determine that. But while someone's living, there's really no direct way that you can measure. So people have tried to estimate. But those are the studies that have been used to justify muscle mass differences between Blacks and whites, which it doesn't really add up. It doesn't make sense because how can quantify such a large population having larger muscle mass? I mean, I was a former athlete, track and field athlete. And so, to say that someone has the same muscle mass as me, when who I actually, exercise all the time, have muscle mass memory, that someone of the same race has the same muscle mass as me, or we have more muscle mass than a white person, it doesn't really add up. And so that was the basis of those biological differences that they found. But now we know that there's actually probably more factors that play a role in differences in creatinine that perhaps may not actually explain the difference between Blacks and whites. So muscle mass is likely not it. High protein diets can affect creatinine levels. We don't really know how to measure generation of creatinine in the body, nor do we know how to measure the elimination or secretion by the renal tubules. And so these are some things that have never been investigated. They have not been investigated in any of the EGFR equation studies. And it's something that we need to look carefully at because we are perpetuating this bogus concept that Black bodies are different than all other racial bodies.
Okay. And then just to set the stage a little bit further, how relative to the number of non-Black participants, were there a significant number of Black participants in the original studies from which these equations were derived?
So 197 for MDRD, and then the next level equation, CKD-EPI, had significantly more Black participants. So 31%, there were 2,800 or so participants in the CKD-EPI study. But they still found the same differences at any given measured GFR. They found that Blacks had higher serum creatinine levels compared to whites.
And in MDRD and CKD-EPI, how was race assigned?
So it's that remains to be seen. It's not in the paper. It looks like the MDRD, it was not by self-report. Per the CKD-EPI investigators, the CKD that study was by self-report. So it's unclear how it was assigned in the MDRD study. It may have been through somebody assigning it for participants, which is again very problematic.
And were the assignments binary, Black versus non-Black, as it is for the equation, or did they lump all the other groups together because there didn't seem to be any difference in GFR in the other racial and ethnic groups?
That's absolutely right. They lumped all of the other races together. So it was Blacks versus non-Blacks.
Okay.
There are other races in those studies.
Okay. So that sort of sets the stage. So you have been very prominent in voicing the opinion. I read your your JAMA opinion piece that you wrote with Peter Reese about why you think that using these equations or using the race modifier is not the right thing to do. Tell us a little bit about why you feel so strongly that that we should not be using the race modifier in the with these estimating equations.
So again, we are looking at a social construct, which is race. And we are introducing that into a biological factor, which is kidney function. And so it doesn't make sense. In the Human Genome Project, they didn't find that any group of genes tracked with races, right? And that we're actually more alike in between races. And so it doesn't add up. And what it does is that it perpetuates these racist narratives that Black bodies are different. So we go all the way back to slave experiments when slaves were told that their skulls were smaller than whites. And we're thinking of things like that, that very unjust experiments and perceptions that have been perpetuated in this country for quite some time. And so, when you're a clinician and you're in the patient and you're in your clinic room and you're seeing your patient, most of the time you're not asking your patient, hey, what race do you self-identify with? You're going in the medical chart. It's unclear where you're getting that race, or it's unclear how that race got into the chart. Did the patient call when they were doing their registration and say their race, or did they come in with some type of trauma in the emergency room and some administrator in the emergency room took a look and put a race in the chart? So it's unclear. That's number one. And there have been some studies that have looked at what happens when clinicians hold false beliefs about biological differences and how that can affect care. There's a prominent study that was published in the University of Virginia that showed that among 200 or so medical students, white medical students, those who held false beliefs about Blacks versus white patients were more likely to rate a Black patient as having less pain than a white patient. So if they believed, for instance, that Blacks had less sensitive nerve endings or thicker skin, those kind of beliefs are what would basically um, resulted in them rating two patients with similar presentations, but just Black versus white. They rated that Black patient as having less pain. So we don't actually know what kind of implicit bias is being brought into the nephrology counter, because we all were taught that Blacks have greater muscle mass. So does that mean that you maybe think that Black patients are stronger and mightier? And how is that affecting your clinical management and your decision making? And so that is problematic. The implicit bias piece is a huge. The explicit piece of assigning somebody a race to determine which EGFR to use, and then the implicit bias of, we have been taught that there's greater muscle mass in this population. How is that? What is that doing in the clinical encounter? How are we then making medical decisions for our patients? So, well, Pals, did you have a question? I see your mouth moving, because I could go on. I'm like, there's some things that we wrote about in the JAMA article that I could say, when what Peter Reese and I, what we think is acceptable for using race, when we think race is acceptable to use.
Well, describe those. Where do you think it is acceptable?
So there's four criteria that should be met. It should race should produce a substantial benefit in that situation. It should be patients that do not want to use race should be accommodated. There should be no other option. And then the fourth one is, hold on, I'm blanking. The fourth one is that I just blanked. Oh, that patients who that the use of race is transparent. That's what it is. The use of race is transparent. Those are the four things that we think should justify the use of race, and race and EGFR do not meet those criteria.
Well, I think one of the problematic things about our concept of race in the United States in particular is that when we're talking about Black versus white, that it's it's usually a binary choice. And there's this very interesting paper that was just published in the American Journal of Human Genetics using the 23andMe database, which, we know that the Black American ancestry is very complex. There was a lot of admixture, particularly with men of European ancestry men with African ancestry women.
Mm-hmm.
And so the ancestry is very complex. And
Mm-hmm.
so it makes categorizing people in a binary way very, very difficult, because who knows what the genetic components are and how much of what we see that we think of as being racial differences that have a biologic basis are really more of a social issue and a social construct than a biologic construct. And I think that's one of the main takeaways that I got from your opinion piece, is that much of what we think of as being biologic probably is not biologic, but has more to do with social structures.
Absolutely. And and you brought up a great point. What do we do with mixed race? What do we do with someone that has a Black parent and a white parent? how do we accommodate for those patients? And again, what are we doing with all other races? I mean, it's just really, again, perpetuating this racist notion that Black bodies specifically are different than all other bodies. And so the ancestry thing, I think, is key going forward, but not to substitute ancestry for Black. I mean, it's really looking at individual ancestry. Just as you said, that New York Times article did a beautiful job of describing the study that you just talked about, that shows that where we think that many of the slaves, like Black slaves that were African slaves that were brought to this country, where we thought they were coming from is not what happened. And all the admixture with European ancestry from, sexual violence and such is really makes things very, very complicated to just be able to assess somebody by their phenotypical appearance and say you have this much ancestry. So I think ancestry is key, but we have to use it in a responsible way and look at the individual ancestry before we can determine disease risk. Yeah.
So, um, since your opinion piece was written, and since a lot of institutions have changed their policies,
Mm-hmm.
there has been controversy, right?
Yes. Yes, there has.
So I want to touch on some of the controversies and play devil's advocate.
Okay.
So we know that African Americans are less likely to be included in clinical trials, and that's something that all of us in medicine want to see more participation by, and that has another whole complex set of reasons for which African Americans are not as represented as they should be. But when we move, if we remove the race modifier from the estimating equations for GFR, that's going to move a significant number of patients from one category of GFR to a lower category of GFR that would disallow their participation in clinical trials. What do you say? How do you respond to that criticism um, that we may be excluding people from participating in clinical trials, that we may be falsely categorizing some muscular men in particular who maybe bodybuilders, may have a large muscle mass, who may not be able to buy life insurance, and other considerations? How do you respond to those critics?
Yeah, so that's great that you brought up that point. How I respond to that is that onus is on the nephrology community to take charge and to rectify some of these things that are causing injustice, that have caused injustice. We don't operate in medicine by looking at one number. For instance, KDIGO, which is the governing, our international governing body that sets guidelines for us to follow, says that we can use either the CKD epi equation, the MDRD equation, or 24 urinary creatinine clearance to determine whether someone is eligible to gain waitlisting time. So my push would be for clinical trials, since we know that creatinine is not a perfect biomarker. We've talked about this for many, many years in the nephrology community. It does not help for patients who are amputees, for frail patients, for muscular patients. We're constantly having to confirm their kidney function for those subset of patients with other methods, which we do all the time. And so for this situation, I would say the nephrology community has to step up and think about ways that we can look at other confirmatory methods of measuring kidney function to allow someone to be in a clinical trial, or to allow someone to gain waitlist time for kidney transplantation, or allow someone to be referred for nephrology. I don't think it's that difficult. I think that there's some workarounds that we as a medical community would have to adjust to, but we don't operate typically on just one number. We don't do that for we don't do that for almost anything. We look at the whole entire picture, and that's how we determine what's best for our patients. And so, for a clinical trial, it'd be very easy for the FDA or whoever the governing body is for that trial to say, we're not just going to use EGFR to determine enrollment in this study. We can offer multiple methods of determining kidney function, including cystatin C, which does not perform differently across races. Your patient is eligible if they do a cystatin C, uh, if they use cystatin C with the CKD epi, for instance, to determine their kidney function. If they're eligible with that, you can enroll them. So I don't actually think it's that binary where it's going to be so hurtful, because again, as a nephrology community, we've been confirming, we get patients, and I'm sure you can think of hundreds of patients that have been referred to you who are much older, who are, who are very frail, who are very muscular, and they've been stamped with chronic kidney disease by their primary care office. What do? We confirm the kidney, we confirm or refute the diagnosis of kidney disease, and we take it off their chart. So life insurance or medical insurance issues or disability insurance issues are no longer once they see nephrology. And why can't we do that for all of our patients, including Black patients that are seen without equations that have race in them?
Well, I agree with you on that, and I think that one of the issues that I see is that these equations have problems not just with race, but they don't perform well at lower ends of the serum creatinine in frail states, people with low muscle mass, people with large muscle mass. We as nephrologists understand that,
We do.
but it's the primary care doctors who are seeing the bulk of these patients before we see them, and some of them are getting to our hands where we can, have some impact on the diagnoses that go into the chart, and some are not. And so I
Mm-hmm.
think I think we as a nephrology community have a large job to do in educating the larger community about the limitations of the estimating equations and how to use them appropriately.
Absolutely. And I think it's also a push to the scientific community that looks at this, that we need better biomarkers. It's not a good biomarker, creatinine. And why are we holding so tight onto holding on so tightly onto it when it's not a good biomarker? A good biomarker does not perform differently across different subsets of people. And so I think it's a push to the scientific community. I think to the clinical community, we have been asking for primary care, for other specialists to refer patients much earlier than they are currently being done. We've been asking that for decades. And so removing race from EGFR, yes, it may cause an influx of more consultations for us to really, to look at the nuances of that specific patient and see, do they have kidney disease? Do they not? How severe it is? But we've been asking for that for years. And so I personally don't see what the problem is. I think in the context of a pandemic, implementation is going to be very hard. I agree with that. However, I cannot justify continuing to use an equation that introduces so much bias. Something that was so statistically accurate is so biased by these things that we can't measure. So that's not right. That's just not right. And I personally have spoken to, especially the younger generation, so medical students, trainees, people who are actually taught in the classroom when you and I were not taught in the classroom about this, that just feel wrong. It feels wrong to judge people, and to do this when we don't have a good understanding as to why we saw those differences. We need to do a better job about that.
Well, speaking of students, I actually first heard about, because to be honest, I'd never given much thought to how the equations were developed,
Mhm.
until Melanie Holnick from Beth Israel Deaconess Medical Center came to talk to me and told me that it was a group of Harvard medical students who came to her and said, "Does this really make biologic sense?
Mhm.
What we're doing?" And so I think Beth Israel was one of the first institutions to stop using the race modifier, and it was all really driven by a group of very interested Harvard medical students.
Absolutely. I think the medical students are the catalyst here. I mean, people in the nephrology community, I think there's pockets of people that were grappling about this, kind of, grumbling about this race and EGFR thing for a long time. But it's really the medical students and the trainees that have just put fuel to the fire and said, I'm not standing for this. And their activism is, very commendable. And I think we as a nephrology community specifically need to get on board and make sure that the next generation of doctors are practicing medicine responsibly and practicing science responsibly. We are not setting a good example if we continue to use these flawed methods. We're just not.
You talk in the JAMA piece about transplantation and how a Black person and a white person with the same creatinine using the estimating equations with the race modifier, the white person might be listed for kidney transplantation, and the Black person not, because the GFR was above the arbitrary cutoff for listing for kidney transplantation. While that is true, do we have any evidence that that is a clinically significant issue for any patients? do you have any anecdotes or anything? Because I think I think putting faces to real stories. So, because as I was thinking about it, I said, well, it doesn't seem like it's probably a clinically significant difference, but tell us what you think. What's your experience been?
Yeah, I do. And we've had these off camera discussions before. I have kidney disease that runs in my family. I'm a first generation Nigerian American. I know that APOL1 disease specifically, for instance, is endemic in the area of Nigeria where my family comes from. And so I have had very close family members, their nephrologists in the community would not list them, would not even refer them to transplant nephrology because the EGFR was above 20. And so it really took my advocacy and the way that we practice in academic medicine, I think, is maybe a little bit more nuanced. Like we said, we can do some other things to look at kidney function, but in the community, and I worry about communities that don't have a lot of resources. That's not the case. They're going off of one number. And again, who knows what other implicit biases are being introduced into that encounter. But I have a family member that has now lost years of waitlist time because they were right on that border. And their community nephrologist did not agree with referring them to transplant nephrology until I stepped in.
Well, thank you, Amaka. That is a great segue into the next part of our conversation. And I think your story. I think one of the things I want to make sure our audience understands is that the disparities in kidney disease are such that I don't know a single African American nephrologist who has not had a family member who has not been touched by kidney disease. In my own life story, the first person in my family that I knew to have kidney disease was my first cousin, who was significantly older than me, but we were first cousins. And she lived in Cleveland, was on dialysis, had a kidney transplant until that kidney transplant failed. And then she went back on dialysis and died prematurely in her 50s.
Mm.
And the second was my mother's sister, my aunt, who had diabetes and developed diabetic nephropathy and went on dialysis in her 60s and lived into the age of 80. So it's a very common story that kidney disease is that prevalent in the African American community. Tell us a little bit about what the situation is like where you are in Philadelphia. In our first session with Denise Thornley Brown in Birmingham and opioid obesity, we talked a little bit about their experiences in Birmingham and Boston and Durham. Tell us a little bit about what you're seeing in Philadelphia, and has it changed over the years since you left and came back?
So it's quite bittersweet because I think in many ways I was in a bubble in Boston. Boston has I know there was this piece that came out in the Boston Globe that looked at wealth disparities, health disparities between blacks and non-blacks in the city. I think that came out in 2018, right when I left. It just showed huge disparities. There's a lot of wealth in Boston, and there's a lot of academic centers and biotech centers. So I just feel like there were a lot of resources around, and many of my patients, I didn't have that many Black patients, but many of them were able to have resources or have ready access to resources to get great clinical care. In Philadelphia, this city is 40% African American as opposed to, I believe, 20% or 25% in Boston. So there's a greater proportion of Blacks in the city, and there's a greater proportion of impoverished individuals in Philadelphia. And so my patient population has changed significantly, which is what I wanted. That's exactly the population that I've been trained at Meharry Medical College to take care of. It's the core of my research. And so, really interacting with them has been deeply meaningful to me. I'm having patients that are referring their friends that are out of network to come see me because there's like, we hear there's a black kidney doctor at Penn, and I'm actually the first Black kidney doctor on Penn's faculty ever in the history of Penn. And so they are just overwhelmed with joy, and it's such a pleasure taking care of them. And I see the same issues that have been published nationally about disparities in access to care. Prognostic awareness is very low. They're most of the time very unaware of their disease or the things that contribute to their disease. So it's very, very impactful to me to be able to fulfill that need and empower patients by caring for them and providing education and resources, et cetera. So it's a shift. It's a shift in the patient population that I'm treating. But I think there's a lot of good work that we can do to improve the health outcomes here.
What do you see as the major um, underlying social issues, social and economic issues that we don't need to talk about biology because that's complicated. We've talked about that with Opie a few weeks ago. But let's talk about what you're seeing on the ground in terms of social issues that drive some of the disparities in not just in kidney disease, but in health outcomes in general.
Yeah, so there's a case. I gave a talk at American Society of Nephrology that I cited this case because I always cite the cases that really strike me, and I'll talk about it in future talks as well. But um, patients who don't have much are labeled, who don't have many resources are labeled as difficult. They end up relying on the healthcare system for basic social needs. And instead of us as a healthcare system embracing them with our $1 billion, we label them as difficult and we try to discharge them. And so there's a case that really struck to me of a very young female, and actually there's a few cases that I had in Boston as well, who are Black, who have sickle cell disease and then end stage renal disease on dialysis from that, and are labeled as difficult, as labeled as pain seeking. In particular, the patient that I had here was a single mother of two children, was homeless, didn't have a lot of families, was in halfway homes, so didn't have any social support, didn't have a home, had real pain, didn't have clinical follow up because since she didn't have a home, she couldn't get a dialysis unit, and so she was always coming in volume overloaded, which had to contribute to her pain and her sickle cell disease. Um, and so, not plugging those patients into the resources that they need, and not being cognizant of the structural racism that has caused an unequal distribution of resources in this country that map very closely along racial lines is a huge issue, and that we're in medicine, it's starting to become more recognized widely. I think many disparities researchers like myself or people like you who have been, advocating for this for a long time have known this, but I think the greater medical community is starting to recognize that it's not the patient's fault and that we should take that onus on ourselves. We have the resources to plug them into social services, to get them into a transplant evaluation. These are young. Some of my sickle cell patients are very young and actually could do quite well with the transplant, but we keep discharging them home and calling them pain seeking and labeling them with all these pejorative words in the chart that causes bias in the clinical counter even before you met the patient. And so I think that in addition to those resources, that patient education is something else that is missing. And that's something a lot of my research is focused on, educating seriously ill patients about their treatment options. So dialysis decision making, end of life care. A lot of the educational resources are unfortunately made on at a very high level kind of reading level. And so the Institute of Medicine a long time ago said that our educational resources should be made so that a sixth grader could read them. And here we are with these we have medical students that don't even understand nephrology. And so we're like giving patients resources when we don't even understand it as a medical community. I mean, look at this GFR thing. There's so much misinformation out there. And so a lot of my work has focused on health literacy, just recognizing the high proportion of patients with kidney disease that have low health literacy, who are frankly illiterate. I mean, functional, have families, but don't read. They memorize getting to work. They make it work and are fine, but are not able to receive that information and then navigate the healthcare system. And so that's where a lot of my foundational work started when I was in Boston, was focused on that very thing. So many things that we could work on.
So it's interesting that, a few years ago, I won't say exactly how many years ago, but when I was, at your level or a little bit younger than where you are now, I didn't know of any healthcare disparities researchers.
Hmm.
I didn't know of it as, an area. We knew that these disparities existed, but we always chalked them up to okay, poverty, poor people are going to have more complications than people
Mhm.
who are resourced. I don't think we really thought about our job in the medical community as being not only to address the medical needs, but also to think about tackling the structural racism, the societal issues that you talk about. We're never going to solve healthcare disparities if we don't think more broadly about why do we these things exist. And I think that's been a fundamental shift in the way in which we as physicians think about tackling healthcare disparities. Is that I think when I was at your level, we were just saying, well, healthcare disparities exist. Poor people have more healthcare problems. Black people have more problems. Mortality is worse. Yes, we understand that as a fact, but we didn't see it as our duty for the most part. Maybe there were a
Mhm.
few people who, but for the most part. So I think that there has been, fortunately, a fundamental rethinking of what our job is as physicians to attack some of those underlying issues. So that leads me to where I want to go for the last part of our conversation. That is what you're doing in your new role. So in this series, we're going to be talking about healthcare disparities and in a number of settings. You mentioned sickle cell disease. One of the things I'm particularly interested in making sure that our audience hears about is the way in which sickle cell patients have been mislabeled as seeking narcotics because of their chronic pain. And Mari Nachebi is going to lead a session for us in which we talk about sickle cell patients in particular. But it can be depressing because we talk about all the disparities um, without talking necessarily about what can we do to fix them. So I'd like to, hear more about how you intend to use your role at Penn in trying to attack some. Where do you see it going to, do something about some of these disparities that we see so plainly?
Yeah, that's a great question. And I'll start with there's just so much to do. I wish I could clone myself, but I have a lot of ideas and I have a lot of energy, as you know. So I'm going to
Absolutely.
get these things done. Um, so I think first with the just what you said with the patient care, like just starting there, uh, there needs to be more emphasis on social services. As of now, without, for instance, a great social worker or resources for a social worker for the population that we just spent the majority of this session talking about, that's absurd, right? We are then physicians, staff members are trying to all cobble together to play a social worker. It's not working. And so I think pushing or advocating for resources and abundant resources to support social services for instance, the nephrology division is one goal to improve patient care. I've already worked on some of the patient education, and so making sure that that's received in a way that patients are again empowered and able to engage into effective shared decision making with their clinicians and their caregivers. And then on the structural side, I think we're thinking about the so many aspects of life are affected by structural racism. And so when we think about diversity, inclusion, and retention, I think a lot of programs have focused a lot on faculty and trainees, which is great. That's definitely going to be a part of my role that I continue to do, that I've been doing since day one. But we don't talk about the staff. And I think that there's a class and power dynamic with the staff and the division. So already, I have, elicited anonymous reflections from the staff who are mostly African American to kind of hear about their experiences. And I want to make sure that they're having positive experiences, that they are having appropriate kind of career development discussions because we again tend to focus on the faculty and trainees, but we should be embracing the staff as part of our family as well. And if they feel part of our family, then there can only be good patient outcomes. And so thinking about their career development, thinking about recognition, it can't always be the clinician educator that gets the award every single year or the best fellow of the world. Like, what about the staff? I think that is a huge, huge piece of it. And then also thinking about how we can enrich our scientific community. So not only should we be focused again on, as you said, improving our the diversity of our participants, really building relationships with the surrounding Philadelphia community. We sit in West Philadelphia, which is has a large proportion of Black residents. Really engaging with them to not only recruit but to also disseminate our research and to really get the messaging out there. When I left Boston, there was this phenomenal work that was happening in one of the large AME churches in Jamaica Plain that was focused on disseminating information about advanced care planning and end of life care. And it'd be something along those lines where we're really going into churches, into engaging with community leaders and activists to make sure that it's not just take, take, take. We want patients, we want diversity to meet these check marks, but no, we actually want, consideration of patients that come from all walks of life, in particular Black patients, and we also want them to learn in the process what the science is doing, what kind of changes we're making, and hopefully we can build in that manner. Um, Also, I'm very interested in pipelines, and so engaging, it can be one off, and I'm always happy, and I've been doing this is to accept students who are interested in doing disparity research, and there's a lot of them. I feel like every year they're just growing exponentially at the number of students who want to do exponential research. But let's put our money where our mouth is, and let's actually have endowed fellowships or scholarships that come out of the division that will support recruitment either from the local colleges, HBCUs. I think HBCUs are completely overlooked in academia in terms of they are the institutions that still train the greatest proportion of Black physicians in this country. Engaging those communities early on into rigorous scientific research is something that's very, very important to me. And so, in addition to again to the diversity inclusion, staff inclusion, research, and building our scientific scholarship with community engagement, I think those are the basic. Oh, and also really addressing incidences of bias in a way where it's constructive and people can learn. I think implicit bias, where the implicit bias research stops, is that once you're aware of your biases, that's it, right? Like no one else knows what to do. And there's just been some interesting things that have come out that some researchers have worked on, mostly in the corporate setting, that a team-based approach, so confronting biases in a way where you're actually calling someone out and be like, why did you say a sickle cell patient was a frequent flyer? Like, what? Tell me more about that. Like, kind of doing that in a way, as well as a societal, like individual. There was a really interesting piece that came out of NPR a few weeks ago that talked about implicit bias at the individual level is not even close to what the societal implicit bias brings. So they were looking specifically at police brutality in communities of color, and they found that it wasn't the individual implicit bias of police officers, for instance, that was causing disproportionate police brutality against Blacks. It was actually the society. If you actually measured implicit bias in the whole community, it was implicit bias against Blacks in the community that was dictating that. And so we need to be able to work on things that can, at a systems level, um, address bias. And so one is a team-based approach. The other thing is changing the default. So this goes into race and EGFR, but taking race out of the equation, changing the default. We learned from behavioral economics that that can have a huge impact on decision making without restricting choice. And so thinking about things like that are things that I'm interested in with this directorship.
Great. So there's a lot. There's a lot there, but I want to focus on a couple of threads through what you said. One is that, if we think about pathways to get people of color into the middle class, I was listening to the news this morning talking about the post office being poorly funded. The post office has been traditionally a pathway for African Americans to move from poverty into the middle class. The other has been healthcare.
Mm-hmm.
So working in healthcare, working in hospitals, steady jobs. And so I think part of my conversation with Sajjan Jain last week was about the responsibility of healthcare institutions, large hospitals that are doing okay, to make sure that they are reaching into the community, hiring practices that reflect the community, and that they're paying a living wage. That can make a big difference in the life of a community.
Absolutely. I mean, again, it all comes down to the social determinants of health, and I see it in my patient care all the time. And I'm sure this applies to not just patients, but I mean, it applies to me, right? If I'm worried about money, when I was a resident, juggling my student loan payments on my, my resident salary, that was stressful, and it's hard to focus on so much when you don't have those basic things in place. And so I think a living wage is huge. Feeling valued is another big piece of it. And so I think we do have an onus, again, like you said, large medical centers that have, infinite resources to pour that into the community, and make sure that people are valued and that they're getting compensated and that they're reaching their own career milestones the way that we are. And that's the only way that this is going to work. So,
And we saw that here in Boston, where the healthcare workers who were diagnosed with COVID were healthcare workers who largely worked in environmental services and food services, who came from poor communities where the prevalence of COVID was high. And so we see these disparities in our own institutions in terms of which healthcare workers were getting sick. It
mm-hmm.
wasn't that people were acquiring the infection in the hospital setting, it was they were acquiring it in the communities where they lived. And so we as healthcare institutions have to be thinking about our own healthcare workers much more holistically than I think we have been uh, before.
No, absolutely. And I think, before we went live, we were talking about performative justice versus reformative justice. And so it is great to educate oneself about racism in this country, reading How to Be a Racist or How to Be an How to Be an Anti-Racist by Ibram Kendi, reading The Case for Reparations, that beautiful Atlantic piece, and thinking and really delving deeply into the history in this country of structural racism is just the first step. And I think having book clubs and journal clubs and really becoming aware of this is just the first step. And I want to make that clear. So kneeling, healthcare workers that were kneeling in support of George Floyd and the justice for George Floyd was beautiful. It was amazing. We did it here at Penn too. First step. It can't be the last step. The next step, as you said, is to really think about our resources and how we're using our resources to really to really push the needle forward and to start to break down some of these barriers. It's not going to happen any other way.
As the Reverend Tracy Blackman, who is a minister in St. Louis and a nationally known social justice activist, once said, that she tells people, particularly her white friends who say they want to know more about how to be an anti-racist, she says, you've got to do your own work. You
Mm-hmm.
have to do your own work to understand this phenomenon. In our last few minutes, Amaka, I want to talk about pipeline, because that's the other
Sure.
thing that you talked about. Um, you mentioned you're a proud alumna of Meharry.
Yeah.
Think it is still true that more than 80% of the physicians, African American physicians in the United States, have been trained by Howard Meharry, Morehouse, and Drew.
Mm-hmm.
And we have a big problem with pipeline, particularly with African American men. Tell me, to the naysayers who might say, well, why does that matter as long as the physician is providing good care? Why do you think it makes a difference to your patients in Philly who are so glad to have an African American woman? What are you doing that's different? Why is it important to them to see someone who looks like them as their doctor?
Well, what's been published so far is that, I mean, the trust is there. The relationship building is that much easier when you have racial concordance. The communication is better, the follow up is better, the relationship is stronger, and so patients feel more empowered. And there's trust. I mean, I've had patients, and I'm sure you've had many patients say, "Well, I trust you," and they'll say, "I don't trust this doctor, but I trust you because you're Black and I'm Black," and just that right there is priceless. And I'm not saying that all doctors of all races shouldn't strive for that relationships. I have beautiful relationships with patients of other races as well. But there's just something there that you can't create. That just happens organically when you have racial concordance. So thinking about Black men, and what they can contribute to our patient population with these huge disparities, especially among Black men in health outcomes. It's just something that it is a public health crisis. That's how it has been defined. It is a public health crisis that the proportion of Black men who are matriculating into medical school has literally not changed since the 60s. And so what is going on there? And I think a lot of it is, they've talked about leaky pipelines. And so they'll get into medical school, but they don't feel supported. Maybe they're the only one in that medical school in their class. There's so much bias that they face, so much microaggression. Who knows what else is going on in their personal life, right? What if they have disabilities, if they have illness, and so really fixing the leaky pipeline is a huge part of advancing health equity and fixing this and addressing this public health crisis of the dearth of Black men in medicine. We have to do a better job, and I think we do have to focus on HBCU undergraduate programs as well as medical schools, because those we were trained to give back to the community, to go into the rural settings. Most of the graduates, I can say a large portion of my class went to rural communities in the South, for instance, and decided to give clinical care there. We need that. But we also need more scientists. We need more academicians in healthcare as well. We need more policymakers, and all of that has to come through embracing these pipeline programs and mentoring the youth earlier on.
Yeah, I would just add, I think, that a good doctor can develop relationships with patients of all types. But I think for patients who've been marginalized,
Mm-hmm.
that having someone, and patients who've been marginalized and have other reasons to be distrustful of institutions, may find it easier to trust a physician who is, if they're African American, who's also African American, someone who's had the same lived experiences as the patient. So I think your point is very well taken. The other point I would make is that I think that one of the things that having as leaders, people who understand where those patients are coming from. Every time I lead a team of residents, one of the things I get on my high horse about is when I hear a 20-something resident calling an 80-year-old African-American woman by her first name. Because they don't understand the history of the great migration of African-Americans from the South and how Black people were systematically demeaned by not giving them a title. And that is offensive to an elderly African-American woman. But it's something that haven't been taught. And unless we are there to give that education, it's often missed.
No, you're absolutely right. Which is why we need more of us, like I do the same thing. You're constantly having to course correct and teach and teach and teach and teach and teach and teach again. And it's something that I've been built to do. And I think it's needed. But again, a few of us sprinkled here and there in rural communities and sprinkled in academia, sprinkled in policy, that's not going to get the job done. That's not going to get us to where we need to be. So I totally echo everything that you said, and we need to do better.
Well, thank you, Amaka. Our time is winding up. So I want to say first, thank you to my friend and former colleague, and I'm also proud to say one of my mentees, whom I take credit for all of your success and seeing you where you are. It makes me so proud to see you to be so successful, and I wish you all the best in your career. And I know you're a rising star, and I look forward to following your career.
Thank you. Much love to you, Kevin. Thank you so much for having me.
So as a closing reminder, attendees may gain continuing education credits for participating in today's session. To do so, please click on the link in the description below this video window to complete the evaluation and obtain the credits. This information will also be distributed through a separate email to today's participants. Please feel free to distribute it to anyone whom you feel would benefit from the discussion. Next week, Dr. Enrique Caballero will be leading the session, in which he'll be talking about healthcare disparities in the context of diabetes mellitus. Again, thank you. And Amaka, again, thank you for taking the time to be with us today.
Thank you so much, Kevin.